as a family physician, LASIK, the costing, can we fix a rough amount that we can say if somebody charges maybe 30,000? Is that an average price for a LASIK? Or it really depends on the surgeon factor, on the equipment, and because you have a lot of charitable institutes supposedly doing stuff.
Well, let's start from the bottom. We have JJ Hospital has just recently started doing LASIK, and it does it for I believe 8,000 rupees, 7,000 rupees for both eyes. So we started from there. But an average cost for a LASIK runs anywhere between 15 to 30,000. That's not the amount I charge. I charge much more, but that's a different story. It also depends on the instruments. You see, the way I look at it is very simple. Cataract, you can do, a good surgeon can do a reasonably good cataract with a razor blade and a faucet. But if you want good quality LASIK, you need a good quality instrument. There is no getting around that. You also have to be very sure about your microkeratones. If your microkeratones are not up to the mark, your level of complications will become inexorably high. So I would be a little hesitant about cheaper LASIKs as the thing goes, and would suggest that you choose your LASIK surgeon, as we tell everyone, by the quality of his equipment and by the quality of his experience, essentially. But there is no cheap LASIK, and there's either good LASIK or bad LASIK. Right?
All right. Thank you. And we're coming to our second topic, which is the most common topic of the bread and butter of every ophthalmologist, which is a cataract. As you all know, cataract is basically an opacity in the normal traditional cataract surgeries, which were done were known as extracapsular cataract surgeries, large incisions, sutures taken. Patients used to be asked not to have a hair bath for a month. And we now have the era of phacoemulsification. Even in phacoemulsification, you have further advances. So I'd like Dr. Keiki to enlighten you all as a crowd to know what are the advancements in phacoemulsification.
Well, I came from the time when the latest advance was considered to be cryo, where you used to put in a little probe and you pulled out the lens, and it looked very great in those days. But essentially, all the advancements which have occurred, or let us say the last 45 years, have been only those which can progressively decrease the opening and increase the safety. The olden day methods of doing a cataract extraction was to cut literally the eye open, which was roughly a 12 to 14 millimeter incision, and you tumble the nucleus up. Now you have to understand a little about the lens. What is a lens? A lens is nothing but a fat letter in a thin envelope. The envelope we call the capsule, the fat letter we call the nucleus, in the middle of it. Now, in the olden days, we just removed everything together, we call it intracapsular. We still do it nowadays, especially in case the lens is totally subluxated or dislocated. Then came extra cap, where you left the capsule behind and you removed the contents. The big advantage was that you could put your intraocular implant over the capsule. So, for a number of years, it was the most commonly done technique of cataract surgery. Then came phaco, roughly about 15 years ago, 17 years ago, where you could utilize an ultrasound tip which oscillated and remove the cataract particles. Had disadvantages in the earlier days because if it generated heat and you could burn the edge of the cornea inducing astigmatism, which caused problems as far as vision was concerned. So the next step which came about was cold phaco, where you could use hyperpulse systems. If you take a pulse for a particular second and you break that second into little bits, and then in that little bits you gradated how much of that bit you would actually give ultrasound and not give, is what is called as hypersound or hyperultrasound. Now these are the techniques which made the phaco become colder, or what we call as colder phaco, which didn't cause a reaction, didn't cause any problems. We are now talking of 5 years ago. So we still have time to proceed ahead. Now what else can you do to a tip? You made it cold, you made it smaller, we decreased the size of the tip from 3.2, the incisions dropped down to 2.8, dropped down to 2.2, now dropped down to 1.8. You can't go much less than that because the lens doesn't go through it. So the only other option left was, instead of making the tip just go up and down, why not turn it to the side? which is known as ozil, which came into way, or make it run in an oval form. Now, both these methods cut down the quantum of ultrasound energy. They enable the nucleus to remain stuck to the tip so that it goes on faster. So these are the advances which came upon in phaco. Now what is the next step after that? The next step is very simple. The same femto which will cut your LASIK flap now has the ability to make your incisions and even make your cataracts. So the next step which we are going is to pure laser surgery using femto cataract surgery. Hasn't yet come, but it's maybe about 2 years down the line. It's already available in American selected centers. But leaving that aside, phaco or cataract surgery has now become the most successful surgery with a success rate which exceeds 99.5%. So carefully selected cases, results are exceptional. And I do believe phaco has made it much more safer. The biggest irony of the lot is phaco is not so much useful in the urban population as it is in the rural population, where originally risks of infection were very high, people couldn't see, and you had problems. Now with the advance of phaco in rural areas, it's now made a lot of difference.
Is there any one cataract which you will say you would not do a phaco in for?
Basically, a phaco requires that the lens has to remain in the center stable. So anything which causes an instability of the lens, lack of zonules, a dislocated lens, subluxated lens, you will try not to do phaco in these cases. Of course, there are riders to it. You can now suture your edge of the capsule to the periphery, anchor it up. It's like hanging a hammer in the middle and putting the lens in the middle. But yes, if the lens has a dislocation, a subluxation, then you will prefer not to do it. In the olden days, we used to add one more thing, that if the cornea was not up to the mark, we tried not to do phaco. But that's not true anymore. Nowadays, with cold phaco, you can get away with almost everything.
Right. And how can a family physician diagnose a cataract in his clinic which needs surgery as early as possible?
Two ways. First is what we call it's a very old system. You shine a torch from the side and the edge of the iris casts a shadow on the lens, and if you can see a shadow, you know cataract is formed there. Number one. And number two, of course, is vision. In the olden days, the criteria for doing a cataract was the inability for a person to see even the stop line or the second last line on the chart. And the reason why the cataract surgeons did it was very simple, because in case they misfired a little during surgery, still the patient's vision improved. And now the patient expects to see the last line, so that's a different story altogether. And so as far as it is concerned, of course, you have a chart in your rooms. If he has difficulty reading the last two lines and his vertical number is corrected, then we presume it is a cataract until proven otherwise.
Right. Now, as cataract surgeons, we are aware that any patient who is on prostate medication, Urimax, Stamchirin, can cause a problem to his surgeon when he's operating. So, can you just tell us about that?
Essentially, the problem lies with what we call as a floppy iris. The iris no longer remains stable. You put your phaco tip inside, it sticks onto the phaco tip, gets lacerated, torn, moves out of place. The pity of the whole situation is by discontinuing time, so that let us say 20 days earlier, has no real effect on the iris. It is still just as bad. As a matter of fact, there are papers which have said that even if it is discontinued years earlier, still the effect on the iris remains. One of the ways to get out of it is, of course, to hook the iris up. You use 4 little iris hooks, and the iris is pulled and stabilized to one side, and the problem goes away. But that is an easy way of doing it. But yes, as far as we are concerned, what is essential is not that Tamsurin causes problems, but what is essential is that the surgeon should know he is taking it. If he is aware of it, life is easy. So I think every family practitioner should be telling his surgeon or telling his patient, please go and tell him that you are taking it. Unfortunately, a lot of patients somehow feel they don't need to tell the eye surgeon anything. They will reveal a family doctor to them is like a father confessor. The eye doctor is like the examiner. The less you tell him, the better. He may refuse to do it.